for months. While our study shows promising results, we acknowledge limitations such as short-term follow-up period and the need for further histopathological tests to validate lacrimal gland recuperation. In conclusion, our PRN regimen offers a promising alternative to daily eye drops, providing patients with relief from the burden of medication compliance. Thank you for your kind attention.
Any questions?
Good presentation. I have got a question for you. After injecting, did you get ptosis?
No, we did not get ptosis in any patient. We got a mild allergic reaction in one patient, which was managed by antihistaminics and injection DEXA. And patient was managed there and then itself.
So decrease in surface area, do you think it will attribute it to the improvement in dry eye symptoms?
Sorry, ma'am?
Once the edema comes, the surface area decreases, no? Exposed to surface area. So do you think that will attribute to the decrease in dry eye symptoms?
Once in that happened in only one patient, ma'am. All the other patient, there was no adverse effect in any other patient, ma'am. So that was not considered significant in our study.
So your all patients were only having aqueous tear deficient dry eye or anything more?
So we included only aqueous tear deficiency patient. That's why we conducted the subjective and objective dry eye test.
Okay.
So.
Now I call upon the next speaker, Dr. Palshan Sindhia.
Good morning, everyone. So I'll be starting with evaluation of meibomian glands structural and functional changes in the patients of vernal keratoconjunctivitis using a non-contact meibography. So a little bit of background and association between the severe ocular allergies like vernal keratoconjunctivitis and atopic keratoconjunctivitis and dry eyes is known. And the proposed pathophysiology is that there is conjunctival inflammation, there is post-inflammatory surrounding tissue remodeling, and the adjacent structures like the meibomian glands are affected, and there is anatomical, structural and functional alterations. So this is known. But the literature regarding the effects in VKC patients is very scant. The literature is very scant, and the imaging modality that has been used is confocal, which has its own limitations, like it do not comment on the functional aspect, and the area that it covers is very less. So the aims and objective of our study was to assess the structural and functional changes in the meibomian glands in the patients of VKC as compared to the normal age-matched controls using the LipiView 2. So the various parameters that were assessed under the functional category were the lipid layer thickness, meibomian gland patency and the quality. The structural aspects that were covered were the MG dropouts and morphological alterations. And blink rate was also assessed in this. Materials and methods, it was a prospective, observational and a comparative study with 50 patients of VKC that were compared with 50 patients of age-matched controls. The inclusion criteria in this, we have included moderate, persistent and severe grades of VKC using the Bonini's grade of classification between the age group of 8 to 20 years, and all the children with any active conjunctivitis, use of any medications known to affect the meibomian glands or use of any immunomodulators, they were excluded. I want to highlight the fact that grade 4 and 5 Bonini classification were excluded because they had a giant papillae and they obscured the meibomian glands, and the children were usually so symptomatic that they will not be able to complete the examination part. So our testing strategy was slit lamp examination followed by dry eye evaluation followed by meibography. So under dry eye evaluation, the battery of tests were done like TBUT, Oxford grading, Shermer's 1 and Meibo scoring, in which the expressibility and the quality of the meibum that was secreted was assessed. So we used this Korb Meibo gland evaluator that gives us the specific pressure for the evaluation, and the Meibo scoring was done. And under meibography, the gland imaging was done, lipid layer thickness and partial blink rates were assessed, all using a single machine, that is LipiView 2. And then the images were retrieved, and manually using the ImageJ software, the dropout area was calculated. So the MG dropout percentage was calculated using the dropout area divided by the total lid area, and it was then categorized using dropout. this mebo gland dropout. So our results were the age of the cases and control was comparable, the sex predilection was comparable, and laterality was comparable. We had 38 patients in the moderate persistent grade and 12 eyes in the severe grade. And we had all the three varieties of the VKC, that is palpebral, limbal, and mixed. So these were our results. I'll try to summarize all this, the significant values. So to summarize, the tear film breakup time, it was less in cases than in controls, but the Schirmer's was normal. That means it was an evaporative type of dry eye. The Oxford grading was more in cases, suggesting that there was ocular surface damage in cases. The mebo scoring was more in cases that there was poor quality mebum that was secreted associated with increased plugging. And there was upper lid dropout, lower lid dropout. That mebo grade was more in cases than in controls. So hence suggestive that there is a structural damage seen in VKC patients. And lastly, the lipid layer thickness was less in cases than in controls, suggesting a functional damage. On top of that, we made some correlations between there was a fairly positive correlation between the meibomian gland dropout and mebo scoring. This suggested that the more the dropout, the poorer the quality and the quantity of the mebum that was secreted was there. And there was a moderate negative correlation between the tear film breakup time and MG dropout. That was suggestive that more was the dropout, less stable was the tear film. And there was, we found that there was no correlation between the lipid layer thickness and the MG dropout. So we concluded that there was a functional reserve that might be present in the meibomian gland that was compensating for the lipid layer thickness. So to conclude, the children with the allergic dry eyes have primarily evaporative in nature, associated with thinner LLT and manifest as ocular surface damage. So there is a vicious cycle of inflammation, both due to the ocular allergy and due to the dry eye. So dry eye need to be co-managed in the patients of VKC. Thank you.
First one. Okay, now I'll call upon our Dr. Manpreet Kaur to start with her presentation.
A very good morning to all of you. So I'll be presenting my research on impact of vector thermal pulsation treatment on ocular surface microbial flora in meibomian gland dysfunction. There are no financial disclosures for any of the authors. So meibomian gland dysfunction, as we know, is a chronic diffuse abnormality of the meibomian gland characterized by duct obstruction, which results in altered tear film, symptoms of eye irritation, inflammation, and ocular surface disorder. The conventional treatment focuses on physical expression of meibomian secretions, heat, warm compresses, eyelid scrubs, topical antibiotics, topical steroids, and lubricants have been tried as well. So the newer treatment modalities include eyelid thermal pulsation systems, which are handheld devices for controlled application and warmth and massage. Why? Because the conventional treatment of warm compresses, etc., compliance is a significant issue. Patients do not really follow your instructions. So why is treatment of MGD important? Apart from optimizing the ocular surface, meibomian gland secretions are also a source of contamination with higher positive culture rates from both meibomian gland secretions and conjunctival cul-de-sac in patients with MGD. Staph epidermidis is the most frequently isolated organism, which is also associated with endophthalmitis. So our purpose was to evaluate the impact of vector thermal pulsation treatment on ocular surface flora in meibomian gland dysfunction. So this was a prospective interventional study performed at Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi, in 40 patients with mild to moderate meibomian gland dysfunction. A single sitting of 12-minute vector thermal pulsation treatment was provided. Meibomian gland secretions were sent for culture and MALDI-TOF analysis for before treatment as well as 1 and 3 months after treatment. Inclusion criteria: mild to moderate meibomian gland dysfunction with less than 50% gland area loss as analyzed by LipiScan and a lipid layer thickness of less than 75 nanometers. Any ocular surface disorder, comorbidities, ocular infection, prior surgery in 3 months, inflammation were excluded. Primary outcome was the change in conjunctival flora with vector thermal pulsation treatment. Secondary outcome measures were change in ocular surface disease index and clinical signs, tear breakup time, Schirmer's, lipid layer thickness, ocular surface staining, visual quality, and meibomian gland dropout. So there was no significant change in the visual acuity and quality at 1 and 3 months after treatment as compared with baseline. When you look at the change in microbial flora, pre-treatment 87.5% meibomian gland secretions were culture positive. Culture positivity reduced significantly at 1 and 3 months. When you look at the multi-TOF mass spectrometry, there was a change in microbial flora after treatment. Of note, staph epidermidis, aureus, hominis, and capitis all were isolated before treatment, and post-treatment at 3 months, only 12 patients had staph epidermidis. Ocular surface disease index reduced significantly, that is improved at 1 and 3 months. TBUT, Schirmer, and NEI corneal staining improved significantly at 1 and 3 months. Meibomian gland dropout and lipid layer thickness improved at 1 and 3 months for the lower lid gland loss, not the upper lid gland loss, and this improvement in structure can be attributed to the restored acini activity. So just to conclude, the culture positivity of meibomian gland secretions in 95%, 38 out of 40 cases, with staph epidermidis being the most common cultured organism. A single sitting of 12 minutes of vector thermal pulsation treatment significantly decreases the ocular surface flora in meibomian gland dysfunction. There is an associated decrease in dry eye severity as assessed by the OSDI score and improvement in ocular surface stability as evidenced by improvement in TBUT and lipid layer thickness. The beneficial effect of a single sitting of vector thermal pulsation treatment persists 3 months post-treatment. Vector thermal pulsation therapy may be performed in MGD patients prior to ocular surgeries within 3 months to optimize the ocular microbial flora. This was the first study to evaluate the impact of heat and pressure therapy on ocular surface flora in patients with meibomian gland dysfunction. Thank you for a patient hearing.
During this follow-up period, was the usage of antibiotics avoided?
Yes, sir.
Was it ensured that they do not get antibiotics
Yes,
during
sir.
that period?
Yes, sir.
Why did you just this cutoff age is this 18 years? Because we also did around the age of 12 years, 14 years also we did this LP flow treatment, and the results are quite gratifying.
So we included only adult patients in our study, so that's why.
Now I'll call upon the next speaker, Dr. Bharat Gurnani.
Good afternoon, respected judges. So I'll be presenting my study on evaluating the novel role of ChatGPT in addressing corneal ulcer queries and artificial intelligence powered insight. The authors have no financial disclosures to make. Coming to the introduction, artificial intelligence based chatbot functions are increasingly used for customer service and to obtain information for education, research, and healthcare practice. ChatGPT is one of the latest AI-based large language models generating human-like responses. With the extent of its popularity and use among general public, its potential in answering ophthalmic patient queries remain underexplored. So the purpose was to assess the ChatGPT's capability to deliver accurate and detailed information on corneal ulcers, assessing its application in medical education and clinical decision making. The study aims to contribute to the ongoing discourse on integrating AI into medical practice. It was a cross-sectional study. Sessions were conducted on 30th September 2023. 5-member panel with minimum 5 years of experience, and the online virtual platform using ChatGPT was used to answer questions based on information for corneal ulcer. So 12 structured questionnaires were formulated by the member panel, and the questions assessed were based on general information, risk factors, etiology, classification, symptoms, signs, investigation, treatment, complication, prevention, prognosis, and future. The basic information about corneal ulcer. Each question was entered into 5 distinct sessions, ensuring that models' response were unbiased by previous queries. Each session was initiated only once to preserve the integrity of data collected. The 5-member panel evaluated the response in the end, and each expert independently rated the response on Likert scale ranging from 1 to 5. Median, interquartile range, and range were calculated. So to quantify the evaluators' consensus and reliability, median scores were computed. Statistical analysis included Flesch's kappa coefficient, Cronbach's alpha scoring, Kruskal-Wallis test, Bonferry correction, violent plots were plotted, and this methodology was aimed to provide a robust evaluation of ChatGPT's utility in addressing queries related to ulcer. So this is the first table. It shows the median column shows the middle value of scores given by the evaluator and the interquartile range as well as the range. So these questions were entered into the ChatGPT session, like what is the corneal ulcer, risk factors, causes and types, like so on. So this is how the responses were obtained for each question. Since this was a long table, so I had to cut and put some screenshot. So a detailed response was obtained and responses were assessed. The scores for risk factor, etiology, symptom, treatment, complication, prevention, prognosis were rated highly with a median value of 4, suggesting a strong performance by ChatGPT in this area. The interquartile range was between 3 to 4, indicated relatively high level of evaluator agreement. Classification and investigations had median score of 3, suggesting an improvement in these areas. And the question of signs had a median score of 2 and the interquartile range of 2 and 3, indicating considerable disagreement between evaluators. So this was a second table, or total number and percentage of median scores evaluated by the evaluators graded as very poor, poor, acceptable, good and very good, and this is overall response obtained. So out of 300 response, 30 were responses were poor. Acceptable category was 125 responses. Evaluated 2 assigned the highest number of good rankings. Very good rating were least frequent, and the total of 10 responses were 3.3%. Overall, the majority of ChatGPT responses were considered good or acceptable by the evaluators. So this was the third table showing the t-value and corresponding p-value for the comparison between scores by different evaluators. Some values were more than one, means maybe an error or discourse between for most comparison, the p-value was 0.44, alpha score of 0.05 or 0.01. Comparisons between various evaluators showed a p-value of greater than 1. So combined violent plot was plotted for 5 evaluators to suggest there is a general agreement among evaluators, especially around the median area, and the distribution shape also indicates most scores are favorably leaning towards the higher end. The individual violent plots were also plotted. Evaluator 1 and 2 show high scores on average. 3 and 4, 5 were conservative with their scoring. So this is a Bose-Fisker plot. The evaluator 3 show a tendency to score slightly high, but within a similar range to other evaluators. So discussion, the integration of AI tools in ChatGPT can be a valuable tool for medical knowledge. In context of this study, we find a nuanced and multifaceted picture of AI model. This is the first study using ChatGPT giving insights on corneal ulcer with a higher relativity of agreement between evaluators of 70%. The limitation was image-based questions were not evaluated. Signs and symptoms had a low value, needing improvement in these areas, and the presence of poor rating constitute 10% overall response. So ChatGPT ability to synthesize and communicate structured information effectively demonstrate potential as a valuable tool for information ulcer. Study identifies areas that would benefit from refinement. AI holds promise for lower the cost of healthcare by reducing consultation time and provide valuable tools. That it is also that ChatGPT can emerge as a counseling tool for corneal ulcer in future, warranting further refinement. Thank you, Vanilla.
Good presentation. Regarding the signs and symptoms, low values, no? So how do you think it is going to change your clinical practice?
Yes, ma'am. That's what this study was, to understand whether it really is helpful in clinical science or not. It can answer queries to a layman or a patient, maybe to an extent, but it cannot replace the clinical practice. That's what we wanted to understand from this study. Thank you, ma'am.
Our next presenter would be Dr. Abhishek Kumar Sinha.
Okay, good afternoon everyone. So my topic for today's presentation is autologous serum eye drops versus lubricating eye drops for the treatment of dry eye disease. So as Deuce 2 defines dry eye as a multifactorial disease of the ocular surface characterized by loss of homeostasis of tear film accompanied by ocular symptoms in which tear film instability, hyperosmolarity, ocular surface inflammation, damage along with neurosensory abnormalities, they play etiological roles. The symptoms include but not limited to are scratchy feeling in the eye, tingling or burning sensation, red eyes, photophobia and blurry vision. So study design is a prospective randomized comparative and open label trial conducted by enrolling patients visiting OPD of the Department of Ophthalmology Patients diagnosed having dry eye due to any cause and satisfy the inclusion criteria were enrolled in the study after getting the informed consents. The study procedures followed the declaration of Helsinki and was approved by the Institutional Ethics Committee. The trial was conducted over a period of 4 months after due approval from DEC. 378 patients who visited OPD with typical complaints of dry eye due to any cause were given the option of centrifuging a small quantity, 10 ml of autologous blood, and use of eye drops prepared from its serum, or go with the conventional eye drops. So Schirmer 1 test score and TB-UT were used as efficacy parameters, and safety was monitored on all visits. Subjective improvement in symptoms were duly noted. Chi-square was used to find the association between the categorical variables, and p-value of less than 0.05 was considered statistically significant. So inclusion criteria: participants of both genders, aged 18 and above, presenting with symptoms of dry eye. Exclusion criteria had any known person with hypersensitivity to the study medications, and those who had any other topical ophthalmic medications within 14 days other than tear substitutes, or were prescribed any other topical ophthalmic solution other than tear substitutes, were excluded from the study. Clinical workup included a detailed history and ophthalmic examination, and those satisfying the inclusion criteria were enrolled in the study after obtaining an informed consent. Participants were divided into 2 groups: a group A for autologous serum eye drops, and group B received CMC or sodium hyaluronate tear eye drop substitute for 90 days. So the method for serum preparation was collect the whole blood in microcentrifuge tube. After collection of the whole blood, allow the blood to clot, and by leaving it undisturbed at room temperature, it usually takes 15 to 30 minutes, and then we go to the pathology department, remove the clot by centrifuging it at 1000 to 2000 rpm for 10 minutes in a refrigerated centrifuge, and the resultant supernatant is designated serum. So following centrifugation, transfer of the liquid serum into a clean centrifuge tube using a pipette, and the chamber should be maintained at 2 to 8 degrees centigrade while handling, and serum is then stored in a sterile empty bottles, labeled and given to the patient. This is how we prepared the serum eye drops. We labeled the name, age, and labeled the serum, and then we gave it to the patients in empty bottles. So the efficacy parameters were assessed on day 15, day 30, and day 90. In addition to substitutes used, we advise participants to blink voluntarily more often, and ocular surface disease index was administered to the patients on all visit. It is a questionnaire which included the TFN breakup time, Schirmer test, and adverse drug reaction monitoring. So this is the age distribution. We had the age from more than 18 years. We included everyone, but those who satisfied the inclusion criteria, but less than 18 years we could not include. This is the gender distribution of the study participants. This is the comparison between the OST between 2 groups at follow-up visits. This is group A. Group A is the which we used the serum eye drops, and group B is the one which we used this sodium hyaluronate or CMC. So 87 patients whose autologous serum eye drops were group A, whereas group B were CMC or sodium hyaluronate eye drops. So clinically, autologous plasma was almost equally efficacious to the other tear substitutes, with slightly more improvement seen in TOBT. There was significant symptomatic improvement in both groups, and both groups were satisfied with their treatment. Both CMC and sodium hyaluronate tear substitutes were equally efficacious, and all 3 were safe in reducing the symptoms of dry eyes. So in discussion, the results of the study show that tear substitutes are equally efficacious in reducing the dryness of eyes, as well as it is evident from the reduction of OST scores. The OST score reduced with the treatment in both groups on all follow-up visit. This showed that both tear substitutes were efficacious in reducing the symptoms of dry eye. The results are similar to other studies where improvement in OST scores has been shown with the use of both serum and CMC or sodium hyaluronate eye drops. Both tear substitutes are efficacious in reducing symptoms, as they moisturize the ocular surface, and having a high viscosity increases the retention time, and hence they are beneficial to the patient. Being a part of one's own body, the autologous serum eye drops may have some additional properties which could have been responsible for better improvement in TB-UT when compared to CMC or sodium hyaluronate. So limitations of the study are the inability of the patient to adhere to the therapy, use of an open label study design, and inability to include osmolarity. Study fails to establish any clinical significant difference, and the study aids in open windows to large scale double blinded studies that may be required in long term to validate it. So these are the references.
At one point you mentioned that along with serum you have given substitutes also. Is it so?
No, sir. We had 2 groups in which group A we administered autologous serum eye drops.
Serum only.
Only.
Nothing
And the other group was given other tier substitutes such as CMC, sodium halonate mostly, and some were also given
I
peg.
misunderstood.
Thank you.
Our next speaker would be Dr. Haimanti Chaudhary.
Good afternoon, judges. My free paper is Novel Artificial Intelligence Derived Dry Eye Analyzer in Evaluation of Dry Eye in Vernal Keratoconjunctivitis. I do not have any financial interest in this presentation. Vernal keratoconjunctivitis is a sight-threatening illness in children which also has often underdiagnosed dry eye, and because doing dry eye tests in pediatric patients becomes a problem, so it remains undiagnosed. Deuce 2 has defined dry eye as a multifactorial ocular surface disease which is characterized by tear film instability and hyperosmolarity. These two have a synergistic effect which causes ocular surface hemostasis is disturbed, and this is particularly very relevant in children who gives rise to loss of epithelium because they have a chronic ocular inflammation secondary to vernal keratoconjunctivitis. With this background in mind, our aim was to explore the role of novel AI-derived dry eye analyzer in the evaluation of dry eye in children with VKC compared to normal children. The methodology involved ethical committee approval was taken, informed consent was taken from the guardian of the patient, and then we embarked upon a prospective case-controlled study in a 6-month period. Study participants were children with VKC, and those with refractive error served as controls. The examination protocol was first they were done slit lamp examination, and then dry eye analyzer was done, and after that the traditional Schirmer test and ocular staining were also done. So what does the dry eye analyzer does? It measures the non-invasive breakup time, the tear meniscus height, infrared mammography, and lipid layer interferometry. In non-invasive breakup time, Placido's disc-based white light is diffused into the cornea, and we look for image distortion. In tear meniscus height, it is measured with an inbuilt ruler in line with the pupillary center, and if it is more than 0.2, it is normal, and we can also measure the tear meniscus volume. Infrared mammography is based on the principle of healthy mabum autofluorescence, when an infrared light falls upon it, and then the AI image is superimposed on it, and the first image that you see here is a normal mammography report. The second video is a grade 2 MGD, and the third video is a grade 3 MGD. Lipid layer thickness is based on the principle of interferometry. When colorful light falls on a lipid layer, when there are more interferometric fringes, it says that it is a thicker layer. Our results show that the commonest VKC was the mixed type. Schirmer grading was, however, only positive in 40% patient, whereas overall dry eye in VKC patients were 54.8%. When we compare all the other study parameters, you will note that non-invasive breakup time was positive in VKC patients 41% versus 24% in controls. Lipid layer thickness was abnormal in VKC 65% of them, and in control it was 46%. Mammography scores were 57% abnormal in VKC versus 38% in control. So what we already know is that there is a prevalence of allergic conjunctivitis and dry eye. In our case, it was 54.8%. What our study adds is 2/3 of kids of VKC have abnormal lipid layer thickness. More than half of VKC kids have meibomian gland disease, and Schirmer score can be very misleading in VKC kids because of reflex hyperlacrimation. There are certain limitations of our study, that is the small sample size, and use of digital device history was not taken into consideration. So what are the translational potential of our study? This is how the report of the dry eye analyzer looks like, and you can see it is a color-coded report. When it is the first report is showing dry eye in the right eye, and the left eye is showing a warning. The second report is showing healthy in both the eyes, and then again the third report is a warning in both the eyes. So when we get a color-coded report like this, It helps to identify the type of dry eye. By doing this, we can get image-based targeted therapy can be done, and we know precisely which layer is to be treated. Thank you very much for your kind attention.
The next presenter would be Dr. Arka Chatterjee.
Good afternoon, everyone. My topic for the day is ocular manifestations in a case of tumoral calcinosis. Firstly, I would like to welcome our esteemed delegates to my city. Tumoral calcinosis is a rare genetic disorder characterized by metastatic calcification around the major joints of the body, like shoulder, hip joint, and the ankle joints. In our case, bilateral hip joints were affected. It usually has a genetic predilection. Autosomal dominant as well as autosomal recessive cases are commonly seen. Now coming to a pathophysiology, tumoral calcinosis presents from a disruption in the calcium phosphate homeostasis. In cases of low serum calcium level, parathyroid glands are stimulated which secrete parathormone that, with the help of FGF23 and GAL-NT3 genes, they produce calcitriol or vitamin D3. Calcitriol acts on the kidneys, GIT, and the skeletal system to reabsorb calcium and phosphate. But in tumoral calcinosis, there occurs a mutation in the FGF23 or GAL-NT3 genes, resulting in a disarray in this pathway. Now, our case, a 22-year-old female presented 9 years back with a history of lower limb pain. She was prescribed oral analgesics, taking which she got symptomatic relief. 5 years later, she developed a cystic globular mass of 1 by 1 centimeter in her lower heel. It was excised and sent for histopathology. The cytology reports showed features of tumoral calcinosis. 2 years after that, she developed a cystic swelling in her bilateral hip. It was again excised. A year after that, she developed solid multilobulated lesions at the same site. She was admitted and then referred to the ophthalmological clinic. On examination, we found multiple small rounded lesions in the posterior lid margin of her both eyes. Her other ocular parameters were within normal limits. Fundoscopy was also normal. Her blood investigations were done, which revealed increased serum calcium phosphate and serum PTH levels. Pus was collected under ultrasound guidance from the cystic swelling. It revealed negative for AFB CBNAT, and blood for ANA was also negative. Radiology was done. Digital X-ray, CECT, and MRI showed hyperdense multilobulated calcific lesions in her bilateral hip, which confirmed our diagnosis. The excised lid lesions were sent for cytology. When the reports came back, we saw multiple calcium crystals dispersed throughout the tissues, along with a very important finding, which is the tumoral calcinosis giant cells, which is very characteristic of this disease. These are usually multinucleated giant cells. Now, tumoral calcinosis is a rare disorder with very few cases having ocular manifestations. To our best knowledge, this is only the second case in Indian literature to be reported, and only the first one with external ocular findings. The other cases which were reported showed features like limbal deposits, CNVM, and angioid streaks. Now, tumoral calcinosis, as we said, is a very rare disorder with ocular manifestations even rarer, but we saw in our previous slides that fundus changes can happen. So screening becomes very important in such cases, especially ophthalmological screening. Otherwise, deterioration of vision may occur. And vice versa, if we find such ocular findings in a patient, we have to keep a diagnosis of tumoral calcinosis in mind. Now, as to my take-home message, as we saw that the diagnosis of tumoral calcinosis depends on radiology, the biochemistry, and pathological findings, and the treatment protocol has to be formulated by a combined approach of medical, surgical, and ophthalmological approach. And sometimes orthopedic approach is also needed. So we should not take a standalone approach in such cases of tumoral calcinosis. Rather, multi-speciality approach should be taken, which will help to formulate a better treatment protocol. Here are the references I have used. Thank you.
Okay, can you show your fourth slide? Fourth slide. That this lead margin involvement.
Yes, sir.
So there is no lead margin keratinization, I believe. Those are what are those things? Those deposits in the lead margin.
Sir, these are the calcific deposits which we saw.
Calcific, not lead margin keratinization like that.
No, just calcium deposit. It was sent for HP, sir. That.
Okay. Good.
Thank you, sir.
Now I call upon our next speaker, Dr. Sangeeta Kalida. Okay, sorry. The presenting author would be Dr. Parimita Datta.
Good morning, respected members of the panel. Here I am to present a tale of two cases of OSSN, ocular surface squamous neoplasia, one true and one mimicker. Coming to the first case, that is a 56-year-old male who was HIV positive, presented with a painless, gradually progressive mass for about 3 months. Now this is the picture where we can see that a mass was present in the temporal limbus with underlying flat placoid base and overlying leukoplakia with fimbriated margins covering about 10 to 6 o'clock hours of the limbus with no overlying keratin and pigmentation. So how did we manage the case? Intersegment OCT was carried out that showed a typical picture of OSSN, and after that, since it was the first presentation and involving up to 4 clock hours of the limbus, therefore wide surgical excision with cryotherapy of the margins and AMT was done, and histopathology was sent. Histopathology showed a typical picture of well-differentiated squamous cell carcinoma. Post-operatively, the patient was managed on topical interferon alpha 2b drops, 1 milli-international unit per ml 4 times daily for a period of 2 months. So these are the follow-up pictures at 2 months and at 12 months post-op, where we can see a clear ocular surface nicely reconstructed with no recurrence. Patient is doing good. So this is the case 2, a 65-year-old male with chief complaints of watering, burning, diminution of vision 1/16 in right eye and 6/6 in the other eye, with no prior history of trauma, ocular surgery, or any other ocular surface disease, but had history of thyroid disorder. So this is the presentation where we can see a pseudopterygium in the nasal half of the cornea and conjunctiva from 2 to 5 o'clock area. And in the other temporal half, as we can see, there is a fibrovascular pannus that is covering from 11 to 6 o'clock hours with an suspected feeder vessel present here with underlying cataract of nuclear sclerosis grade 3. So the management was a slightly different approach, as we can see in the video. A combined approach was done where there was first wide surgical excision of the fibrovascular pannus was done and excision of the pseudopterygium was done. Then double free stroke cryotherapy was carried out, histopathology was done, and the LSCD, that iatrogenic LSCD that was created, was covered with the help of autologous sled, as the patient had a normal eye in the fellow eye. The histopathology picture showed a mild hyperplasia of the lining epithelium. So definitely it was a mimicker of OSSN. Now post-operatively, how the patient was managed? The patient was managed on moxifloxacin and dexamethasone combination eye drops and antibiotic eye ointment with oral steroids, oral prednisolone, 1 mg per kg body weight tapered over 1 month. At 2 months and at 12 months, so this was a picture at 12 months. There was good ocular surface reconstruction with an underlying nuclear sclerosis, so the vision was 6/18. Coming to a discussion, in the first case, the patient was presenting with OSS and HIV at the age of 56 years. Usually, the age of presentation is around 35 to 41 years. And also, the incidence is only around 4 to 8%. In our case, the temporal limbus was involved, which is also rare, and also the patient had a unifocal presentation. In our patient, there was a multifocal presentation that was rare. So these were the studies that were supporting. For the second case, ocular surface squamous epithelial hyperplasia, it rarely involves the ocular surface without any definitive triggering event, like no history of trauma, no prior ocular surgery, no ocular surface disease. Hence, it can closely mimic OSSN on clinical examination. And also, our approach to the patient was a combined approach. So it was a rare situation. So conclusion, invasive OSS in elderly male with temporal limbus involvement is rare, but prompt diagnosis and management in immunotherapy can help in saving the patient's eye. Pseudoterrorism and coexisting fibrovascular pannus without any significant past history mimicking OSSN is rare. Thank you for your patient hearing.
Now I call upon our next presenter, Dr. Dhruv Kamara.
Through the few cases that I'm going to show you, I'll try to emphasize the importance of pattern recognition of scleral lesions and how they may help us in differentiating the two conditions and managing infectious scleritis better. So the first case is a 61-year-old female. She presented to us with chief complaints of pain, redness, and watering in the left eye for the past 3 months following injury with a wooden stick. She gave no similar episodes of redness in the past and no ocular surgery history. She had no systemic illnesses and was not on any long-term medications. On ocular examination, the left eye conjunctiva was congested, and due to a grade 4 nuclear cataract, the BCVA was 20/60 in the left eye and 20/50 in the right eye. The rest of the findings were normal. On diffuse slit lamp examination, we noted a scleral nodule inferiorly, yellowish scleral nodule inferiorly with temporal thinning and uveal show, along with dilated episcleral vessels. We did a UBM through this nodule, and we noticed elevated area of hyperreflectivity within the scleral stroma with overlying thin sclera. The B scan showed acoustically clear vitreous cavity and no signs of posterior scleritis. At this point, we asked the patient to get a complete systemic immune workup done, and she returned back to us a week later with the following reports. The ESR and CRP was elevated. RA factor, ANA profile, C ANCA, P ANCA were all negative. The Montauk test was negative, but she was newly diagnosed to have type 2 diabetes and was started on medications. At this visit, when she came to us a week later, we also saw a new lesion developing in the superotemporal region. It was a boggy yellowish nodular swelling. And due to the negative autoimmune profile and positive history of injury with vegetative material, as well as these lesions which appeared at discontinuously almost 4 mm behind the limbus, we thought of it to be an infectious scleritis, and we took the patient for scleral deroofing and biopsy. The pus was allowed to drain out, and the infective tissue was scraped and sent for microbiology and histopath. 10% KOH mount showed septate hyaline fungal filaments, and histopath confirmed the presence of fungi through gomoromethamine stain. We started the patient on antifungals, topical and oral as well. The scleral biopsy culture grew unidentified demataceous fungi 3 weeks after incubation. By this time, the patient was doing well. The inferior nodule had resolved, and the superotemporal abscess had also healed with thinning and uveal show. 6 weeks after this deroofing, a new supranasal ulceration had developed. We deroofed this as well, and we added topical voriconazole due to the demataceous fungi. 10 weeks from presentation, all the lesions had healed with thinning and uveal show. After this, the patient was lost to follow-up. Coming to the second case, this was a 44-year-old female who presented with pain, redness, watering, and diminution of vision in the right eye for the past 2 months. She also gave a history of wooden stick injury to the right eye 4 months ago. Also, there was history of pterygium surgery in the right eye 3 years ago. And there were no similar episodes of redness in the past, no systemic illness, and she was not on any medications. I'll jump directly to the clinical findings. So the diffuse slit lamp examination of the right eye mainly showed 2 scleral nodules inferiorly with pus pointing, and superior-nasally resolved looking discharging sinus was also noted. We did a UBM and found there were 2 elevated areas with thin sclera and decreased refractivity within the scleral stroma. There was no evidence of posterior scleritis. Due to the pus pointing and discharging sinuses, a provisional diagnosis of infective scleritis was made, and on deroofing these nodules and sending them for micro and histopath, no organisms were noted. But because the lesions were so similar to the case that we had seen before, and they were appearing in a discontiguous manner 4 mm posterior to the limbus, we decided to start this patient on empirical antifungals. The patient was lost to follow-up, but continued to use the medications, and a month later, the nodules inferiorly had healed with thinning, but new scleral abscesses had formed nasally. On deroofing them and sending them for micro and histo, again, no organisms were seen. However, again, a month later, those also healed, but a new lesion developed superior nasally, which was again deroofed. But again, there was no confirmation of any organisms in micro or histopath. However, we continued antifungals due to the positive response, and 3 months later, all the lesions had resolved with thinning. So to discuss the important learning points, firstly, it's very important to differentiate immune-mediated from infective scleritis before starting any immunosuppressants in haste, because we need to rule out any underlying systemic disorders before we start any immunosuppressants. Also, it's very difficult to manage scleritis with medications alone because of the dense collagen fibers and structure, as well as avascularity. Fungal scleritis is even more challenging because most of the drugs are fungistatic rather than fungicidal. Another thing we noted is that the lesions which appeared on clinical examination intraoperatively much larger, because these fungi and organisms are more invasive and may remain in the deeper stroma, so you might get negative scrapings, but that does not mean that you should rule out any infectious etiology. It's also important to note the difference between fungal and bacterial scleritis, because fungal scleritis is more indolent, takes a very long time. Like in our case, the injury happened 2 months prior, whereas bacterial scleritis is acute and usually presents as a localized abscess in one area, whereas fungal scleritis presents as multiple nodules 4 mm posterior to the limbus. This typical pattern of fungal scleritis can be explained because of the arterial network and watershed zones in the eye. So if we look at the episcleral blood supply, the anterior ciliary arteries and long posterior ciliary arteries are the main blood supply of the episclera. The anterior ciliary artery branches anastomose to form the episcleral arterial circle, which is 4 millimeters posterior to the limbus. And within this circle, the blood flow is...
Dr. Dhruv, you have cost 5 minutes more.
5 minutes. Okay.
I'll just finish it off quickly.
Yeah.
So the main point is that the arterial blood flow in these areas oscillates, and so it stagnates, and the fungi get a chance to harbor their infection over here and grow in these areas. So to conclude, basically, discontinuous scleral lesions due to intrascleral spread of infection 4 mm posterior to the limbus is most likely suggestive of a fungal etiology, and even if you don't get a histopath or microbiological evidence, you may start antifungals for a better prognosis. Thank you.
Now I'll call upon our next speaker, Dr. Arpita Kulshetra.
Good afternoon, everyone. I'm Dr. Arpita Kulshrestha, and I'm here to share our experience of combining vector thermal pulsation therapy and omega-3 fatty acid supplementation in meibomian gland dysfunction. So the two treatment modalities we combined, one of those was vector thermal pulsation, which was delivered with the help of LipiFlow, which is the FDA-approved thermal device, which applies heat for 12 minutes and followed by peristaltic pressure, which helps in expulsion of the blocked meibomian glands. So it's usually considered in patients who have history of dry eye symptoms with a speed score of more than 8. What's important is the dropout area of meibomian gland should be less than 50% on gland imaging, as it won't be efficacious if there's significant gland atrophy. And it's usually contraindicated if there's active ocular infection or inflammation in the eyes, or if there are any eyelid abnormalities. The second treatment modality that we used was omega-3 fatty acid supplementation. So what we already know is that omega-3 fatty acids are anti-inflammatory and omega-6 fatty acids are pro-inflammatory. And it's a balance between these two which is critical. So overwhelming the metabolic pathway with omega-3 fatty acids would lead to a competitive inhibition of omega-6 fatty acids, reducing the overall inflammatory state. And it was also hypothesized that it would change the fatty acid composition of the meibomian lipids lowering their melting points and thereby decreasing their fluidity and secretion. So several studies have shown conflicting results of omega-3 fatty acid supplementation. So the following studies did show an improvement in various dry eye parameters with omega-3 fatty acid supplementation. However, this DREAM study, which was a large multicentric randomized controlled trial, showed that omega-3 fatty acid supplementation was not significantly beneficial compared to placebo in moderate to severe dry eye disease. So our research question was whether combining omega-3 fatty acid supplementation prior to VTP would be beneficial in the management of MGD compared to monotherapy with the two alone. So our primary objective was to analyze the combined effect on meibomian gland function as seen on LipiView interferometer, and our secondary objective was to analyze change in other dry eye parameters. So ours was a longitudinal prospective interventional study with 3 arms. The first arm received omega-3 fatty acid supplementation of 1200 milligrams per day for 12 weeks. The second group received a single session of VTP, and the third group received combined therapy. Omega-3 fatty acids were given for 12 weeks with a single session of VTP at 6 weeks. And the parameters were assessed at baseline, 6 weeks and 12 weeks. So patients who had a lower lipid layer thickness of less than 60 nanometers, a speed score which assesses the subjective dry eye symptoms of more than 8, and meibography showing more than 50% of gland occupying lid area were included in the study, and patients who had any active inflammation or dry eye secondary to other causes were excluded from the study. So we assessed the subjective symptoms with the help of speed questionnaire. The tear film breakup time, ocular surface dye staining, Schirmer's 2 were also assessed. The meibomian glands were assessed depending on the lipid layer thickness, partial blink rate, and meibomian gland imaging, as well as meibo scoring was done, which is essentially based on the number of glands plugged and the quality of secretion. So what we found was all 3 groups showed an improvement in lipid layer thickness from baseline, and this difference was statistically significant in the combined group compared to the omega-3 group alone. The subjective symptoms as assessed by the speed score also showed improvement in all 3 groups at from baseline. However, the groups where the participants were subjected to VTP showed a great, that is the VTP monotherapy group, and the combined group showed a greater improvement as compared to the omega-3 group alone. The meibo score also showed an statistically significant improvement in the combined therapy group compared to the baseline as well as compared to the other groups. The tear film breakup time improved in the combined group alone, but there was no statistically significant difference between the 3 groups. The Schirmer's 2 improved in all 3 groups. However, there was no improvement which was seen in the partial blink rate or the meibomian gland area. So what we concluded was there was a significant improvement in lipid layer thickness, subjective symptoms, tear film breakup time, and meibum quality achieved in the combined group compared to the monotherapy groups alone. And we concluded that combined therapy with omega-3 fatty acid supplementation could be offered as a novel therapy to patients with MGD, especially those who have a sufficient functional reserve. So here were representative LipiView images of the groups. So as we could appreciate, the lipid layer thickness improved in the subsequent follow-ups. However, there was no improvement in partial blink rate or the meibomian gland area. Similarly, in the combined therapy group as well and the VTP group, we could appreciate that the lipid layer thickness did improve on subsequent follow-ups with no change in the meibomian gland area. Thank you.
Our next speaker would be Dr. Pooja Khamar.
A very good afternoon to all. At the outset, I have no financial disclosures pertaining to the study, and none of my co-authors have. So we are going to navigate through the worldwide impact of dry eye disease, the background and need for personalized intervention, the purpose of the study and why we need to study the role of tear biomarkers, how do we analyze the same, the results, and how to customize the treatment using this biomarker analysis. We come across this 2 group of patients in our everyday dry eye disease practice. One group of patients, they do respond to our treatment, but the second group of patient remains dissatisfied. And they start taking different treatment options, multiple medications, and also at times modern day dry eye therapies, but they remain dissatisfied. A non-responder is a patient who sometimes does not respond to our treatment despite and have clinical symptoms, a tear film instability, and also the corneal surface integrity is not maintained despite treatment, and that is what is known as a non-responder. The global prevalence of dry eye disease is increasing. As many as 350 million patients being affected by dry eye disease every year. And out of them, 60% of the patients report a reduced quality of life when it comes to their routine practices. And this also increases the financial burden to the market and to the families as well because of chronic medications. So we do need to, there's a crucial need of identifying these non-responders using advanced diagnostic technologies and how we can offer a customized approach for the same. So we wanted to identify that why do some patients do not respond to our dry eye disease treatment when they walk into a clinic, and also whether we can have a tailor-made approach strategy for these non-responders and reduce the risk of these non-responders in this clinic and have a happy patient. So our group has developed this BioM Pathfinder kit, which analyzes 8 inflammatory and non-inflammatory biomarkers using a centrifugal technique. It's an ELISA-based technique, and it uses a microfluidic system. We can collect tears using the Schirmer strip, like how we do on a dry eye disease test, but rather than discarding the Schirmer strip, we collect it in an Eppendorf tube and add a patented buffer solution to this tube. We shake the tube for 5 minutes, and after 5 minutes, whatever proteins are eluted in this solution is then taken and incorporated in this well, and then this well is put into a analyzing system, which is the BioM Pathfinder kit. At the end of 90 minutes, we get this biomarker report where each of the biomarker value is given for each of the eye, and based on the reference interval, just like a hemogram or a CBC report, we can see whether it's normal or abnormal. We recruited 502,070 patients who walked into our dry eye clinic, and based on TFOS due to classification, the treatments was initiated. They were followed up at 3 and 6 months, and dry eye metrics and a comprehensive dry eye questionnaire was taken for them, and the non-responders were identified. Further, the non-responders underwent a tear biomarker testing using the BioM Pathfinder kit, and a personalized biomarker-based therapy was initiated for these non-responders. 64% of the patients were identified in our clinic, out of which 27% patient had high MMP9 levels, 17% patients had high ICAM levels, and 20% patients had high combined biomarker levels. Based on the fold rise of MMP9, they were started on trehalose-based drops, or a combination of trehalose and cyclosporin, or a combination of trehalose, cyclosporin, and a vector pulsation therapy. And post-treatment, the non-responders rate reduced to 2.3%. 17% patients showed high levels of ICAM1, where the lifitegrast and trehalose combination was started, and post-treatment, the non-responder rate reduced to 0.7%. For IL-17 patient, the group which is very nicely known as the pain without stain patient, either a sitting of vector pulsation therapy or 3 sittings of IPL were given, and post-treatment, the non-responder rate reduced by 11.2%. And the combined group, where all the biomarkers were on the higher side, a combined therapy of 3 sittings of IPL therapy, trehalose, and doxycycline was initiated, and post-therapy, the non-responders rate reduced to 0.6%. And a combined rate of non-responders from 64% reduced to 4.4% with this targeted therapy based on biomarkers. So using a BioM Pathfinder kit and the reports which are generated, it is not only cost effective to the patient but also to the global market, and the test for 8 biomarkers cost not more than 1,500 rupees, and it can be done by a single trained technician, and it is as small as a projector which can be kept in your clinics as well. So this is the first time in world biomarker kit which may be used to discover and stratify specific abnormal levels of biomarkers and treat them for inflammation as targeted therapy, and more economical management can be given by avoidance of multi-drug therapy in patients with previous treatment failures. This kit can also be used for keratoconic patients, post-op unhappy cataract and refractive surgery patients, diabetic retinopathy patients, myopia and glaucoma. So this kit is ready for use in our
and
clinics.
my team
Thank
for
you.
helping me present this work on their behalf. Thank you.
Our next presenter would be Dr. Praful Kumar Maharana.
Thank you, respected judges. So my topic of presentation is correlation of corneal concentration and MIC of antifungals in patients undergoing therapeutic PKP. It's not moving. So why did we go for this study? You know, fungal keratitis is one of the most common cause of corneal opacity in India, accounting for corneal blindness. And the most common cause that have been implicated for poor response to fungal keratitis is poor penetration of drug. However, when we review the literature, all the studies are practically based on experimental studies only. There is no study that directly measures the corneal concentration of drugs in human patients. Similarly, if you go through the result of MUT1 trial, classically it has been proposed that voriconazole penetration is much better than natamycin, but on the contrary, the results suggested natamycin was better than voriconazole. So there was something is lacking with our understanding of this. So this brought us to the purpose of my study. What we did was we measured the corneal concentration of the most commonly two drugs, natamycin and voriconazole, and we compared that with the MIC90. MIC90, you all know the concentration of the drug that inhibits 90% of the test samples. So just to look for whether these drugs are achieving any concentration in the cornea at all. So this study we did at RP Center AIMS New Delhi in collaboration with our pharmacology and microbiology department. It was a prospective study, and after obtaining the ethical clearance, then we started the study. So we took all patients of fungal keratitis, those were diagnosed based on KOH or fungal culture, undergoing therapeutic penetrating keratoplasty following failure of medical management, and we excluded the other indication of TPK like perforated ulcer, polymicrobial keratitis or impending perforation. Also we excluded those cases which are involving limbus because that would have biased our findings, and systemic diseases where there could be some poor penetration of drug or the immunocompromised status of the drug might have caused the poor response to therapy. So we took the corneal tissue, donor host tissue, we divided that into two parts. One was sent to pharmacology lab for LCMS or liquid chromatography mass spectrometry to measure the concentration of drugs. The other one was subjected to E-strip test. I'll just show you a picture of that. So this is the LCMS setup. This was the E-strip test that we use. As you can see here, there is a zone of inhibition, okay, so, and this value 0.47, that is what is your MIC90 for that particular drug or natamycin. So statistical analysis, chi-square test for categorical data and Spearman correlation was analyzed to look for correlation data for continuous variable. These are the baseline characteristics of this study. I'm not going to the details of it for the sake of the time. The point is both natamycin and voriconazole group, they were similar in all aspects. Most of the ulcer were moderate to advanced grade, and the depth was almost 60% cases it was crossing mid-stroma, and 30% it was deeper. The mean age was almost 48 years. So this is important for the interpretation of the results. So voriconazole and natamycin, they were administered almost 14 days before I think 2 minutes left, right?
Yes.
Okay. So voriconazole and natamycin given for 14 and 17 days respectively, and frequency was 9 and 9. So this was the microbiology. Aspergillus was the most common organism, followed by Fusarium. And intracorneal concentration for voriconazole it was 0.08, and natamycin it was 80. And we compared correlated the various factors like age, gender, duration of treatment, frequency of treatment, time interval from last dose, ulcer area, infiltrate area, ulcer location, and these were the outcome. So except frequency of treatment, none of the factors were influencing the corneal concentration of drugs. For frequency, the more the frequency, the better was the concentration. This was the table of MIC90 and all the individual agents. So I'm not going to into the details of this. This was the summary. So there are a lot of learning points for this summary. As you can see, only in 4.7% cases, both drug cross the MIC90. So the thought process that poor response to poor penetration of drug is a major cause of medical management failure holds true as per our study. Intracorneal voriconazole, the only 9% compared to natamycin, where 33% cases they achieve concentration more than MIC90. So the MUT one's finding that natamycin is better than voriconazole still holds true. Even if voriconazole claimed to have a better penetration, but natamycin is better. But the scaring part was last 2 points. Almost 52 in natamycin and 23 in voriconazole. The MIC was crossing the highest possible limit possible, which probably indicates these organisms probably resistant to the drugs that we were giving. So our study highlighted LCMS can be used to measure corneal concentration of drugs. Second, susceptibility to antifungal must be done if your patient is not responding to therapy, and in addition to drug, other factors do also affect your outcome. So the limitation was LCMS. First time we did that, so that was not standardized. With this, I'll conclude here. Thank you very much for your attention.
Next presenter would be Dr. Anu Malik.
One more.
Two more. Two and one more.
We have.
No, this already done.
After this, there is one more speaker.
That is already done.
Good afternoon, everyone. I'm here to present a study to assess the effectiveness of propylene glycol and hydroxypropyl guar nanoemulsion in improving MG scores and in reducing symptoms of ocular dryness. I have no financial interest to disclose. So as we all know, the dry eye is multifactorial disease of ocular surface with loss of homeostasis of the tear film instability and hyperosmolarity, ocular surface inflammation and damage, along with neurosensory abnormalities. Dry eye disease incidence worldwide varies from 5% to 50% depending upon the age, sex, or the study population. It can be broadly classified into aqueous deficient or evaporative type. So we have a plethora of treatments for dry eye depending upon the underlying cause. Coming to meibomian gland dysfunction, which is reported in about 70% of dry eye cases, it results in altered meibomian gland secretions and tear film abnormalities. It is most commonly acquired in nature, and the meibum secretions are affected. So coming to our study molecule, PEG-HPG nanoemulsion, it is a lipid-based dry eye therapy which is designed for evaporative dry eye disease, and it works on lipid layer and along with mucoaqueous layer of the tear film. It increases the lipid layer thickness also. So this unique formulation also contains excipient which can be used in patients with mixed dry eye diseases, and it restores the complete tear structures to prevent the exacerbation of dry eye and maintains a healthy ocular surface. So the aim of my study was to assess the effectiveness of PEG and HPE guar on MG scores in reducing ocular discomfort symptoms through an investigator-initiated trial, and the primary objective was to assess the mean change in OSDI scores from baseline to day 30 and the mean change in MG scores from baseline to day 30. The secondary objective was to analyze the mean change in non-invasive tear film breakup time from baseline to day 30. We included patients more than 18 years of age, both gender, with known cases of dry eye disease, best corrected visual acuity more than 6/24, OSDI within the range of 13 to 33, Niebert time less than equal to 12 seconds, Schirmer's tears test less than equal to 10 millimeter in 5 minutes, MGD scores more than 20. This was kept in mind to include patients with mild to moderate dry eye disease with normal lid position and closure. We excluded patients who had any ocular conditions like infection, inflammation, trauma, blepharitis, or recent ocular surgical procedures within 3 months. It was a prospective interventional study done at Dr. R.P. Center for Ophthalmic Sciences, AIIMS, New Delhi, and we included 80 eyes of 40 subjects. The eye drops were to be administered twice a day for 30 days, and the study visits were designed at day 0, baseline and randomized visit, and day 30 as study end visit. So we performed baseline investigations, visual acuity, Schirmer's test, ocular surface analyzer, Niebert MG score, which assessed lid margin, meibum quality, meibum expressibility, and meibomian glands loss, and OSDI questionnaire. So coming to the results, the mean age was 33.64 years. We had 42% males and 58% females, and the dry eye disease severity was mild to moderate. So the logMAR BCVA improved from 0.047 to 0.033, and the tear breakup time, Schirmer's test, Niebert and MG score had significant changes at day 30. Moreover, OSDI scores also reduced from 26.212 to 19.442. This is a representative fluorescein stain image comparing at baseline and at day 30. So this was a prospective study of 40 participants, which included mild to moderate dry eye disease. So HPG-PEG forms a soft, thin cross-link in situ gel matrix with borate ions, which prolongs the lubricant retention and provides ocular surface protection. So preclinical and clinical evidences demonstrate that this nanoemulsion is safe and effective in promoting temporary relief of symptoms of dry eye disease. These are the recent studies which have been done for PEG-HPG complex. So I would like to conclude that this was an early experience, but it gave us very encouraging results in reducing dry eye symptoms, improving OSDI scores, stabilizing Niebert, and improving MG scores. Thank you.
Close the session. Okay, the session is over.